Good evening.
Good evening, Dr. Attakorah.
How are you?
Yes, we are fine by God's grace and you.
Are you ready?
Yes, please.
Okay, where are we? It's been ages. Where are we?
Please, the last thing we looked at was the management of hyperphosphatemia.
And somebody apart from you talk about where we are getting to. Can the men tell me where we have gotten to?
Silas, could you kindly tell us?
Hello?
Hello.
Hello.
Hilary, tell them to.
Silas, could you kindly tell us where we've gotten to?
Okay, Doc, please, we ended up where how to treat hyperphosphatemia.
So tell me what we have done so far about the clinical presentation. What we have done so far.
Doc, please, we discussed how to manage anemia, then hyperkalemia, then uremia, then hyperphosphatemia. Yeah. Yes.
So what is left to cover? Are we done with hyperphosphatemia?
Yes, please.
We are done.
Yes, please. Yeah. Then we talked about the dialysis. Yeah.
So what is left for us to cover? Any other? Hilary, can you mention any name for me?
Gloria, could you kindly tell us?
Gloria, are you there? Hilary.
And then polyuria, oliguria, anuria, urinary symptoms.
So,
Urine.
you have been at the ward. Tell me some of the clinical presentation that you encountered when you saw a renal. Any clinical manifestation. Is Nana around?
No, please.
So any clinical manifestation that you saw at the ward.
So the patient that I met had edema and then high blood pressure. There was also anemia.
So yes, last time I told you to check something for me about the iron. Did you do that? Did you check it for me? Class, did you do that for me? Can you mention somebody's name? I want to see whether
Mame,
for the class.
please say that.
No, I don't know. I hope not.
Araba said what?
So you asked them to check the difference between iron sucrose and dextran, the one that you give a test dose to assess the patient's tolerability. And from what I found, you give a test dose for iron dextran, but for iron sucrose, you don't need to give a test dose.
So how many meals would you give? So you said you should give test dose. So how much will I give as a test dose? Any dose as a test dose. Mami Opon, can you help me? Okay, so let me ask you this. Hilary,
Doctor,
your class, I am not so happy about the class. So tell them. The involvement, I'm not so happy. So do this for me, class. Hilary, mention their names. Do this for me. Just want to know. Petty things, small things. If a question like this is asked, this is about Lexis and the renal. So if I ask the state 4 conditions that could lead to octotoxicity when using Lexis in renal impairment, state 4 conditions that could lead to octotoxicity when using Lexis in renal condition. Four conditions that could lead to octotoxicity. The next question is, why is diuretic contraindicated? In other words, I want to be specific. Why is Lexis contraindicated in Addison's disease? So you want to give Lexis tablets to a patient in relation to food. When should Lexis be given to a patient in relation to food? Or when should Lexis be taken in relation to food? Can you help me with these answers? So who can help me with the first question? Can you hear me?
Yes, please.
Is Mami Upon around? Mami Upon, are you there? Hillary,
Dr. Attakorah,
call them.
Khaled Nico, kindly help us.
Hillary, I'm waiting.
Antoinette, help us. MFA, please help us.
Are your people around? Or are they having any network challenge?
Please, they are here.
Hmm?
Yeah, hello, sir.
Yeah.
I think some of the conditions that can cause the ototoxicity are hypokalemia, hypocalcemia. Hello.
I'm listening. Kingsley, I'm listening.
And I think hypo or hypermagnesemia, something like that.
The way you are saying you think, you are not sure. The way you are saying you think, you are not sure.
Oh, I'm sure.
So stage 4 conditions. possible condition that could lead to octotoxicity?
I think it has to do with the electrolyte imbalance.
You think it has to do with electrolyte? You are still guessing. If I ask you, how will electrolyte imbalance cause octotoxicity? Can you tell me? Who can help? So if you have a question like that, how will you go about it? State 4 possible conditions. I have done one with you. And who can tell me that one? Kingsley, can you tell me that one?
Attakorah.
I've mentioned one when I was doing edema. I've mentioned one. I mentioned one when I was doing edema. So when you started saying I think, I realized.
Loop direction.
Class, let me ask you this. Should I stop this class with you?
Oh, no, sir.
I don't see that participation. Anytime I'll be mentioning names. Hilary.
Dr. Attakorah.
I'm not too happy. Mentioning names, I don't know whether it's network, but what is the problem? Tell me. Should I allow only Ishak and Bobo to do the teaching?
No, please.
Is Araba around? Do you have Silat or say there? Mami Okon, are you there? Della.
Della is here.
Della, can you mention one or two for me? State 4 conditions.
You mentioned that furosemide can cause hearing loss. That was the previous lecture. But then conditions that can cause it, I think, no, I don't think, sorry. Ear infections.
Come again. You said the previous lecture, I said what?
You said furosemide can cause hearing problems.
But I attached a condition to it. I didn't make that blanket statement. There was a condition. Who can tell me?
Please, one of the conditions is nephrotic syndrome because of the low proteins in the blood.
So hypoproteinemia. Hypoproteinemia. So low protein can lead to. So that is one of the conditions. So it's not nephrotic syndrome, but it's low protein. So hypoproteinemia, one of the conditions that could lead to what? Could lead to octotoxicity. What again? Rebecca? I know you are checking, so check and tell me. What again?
Please, that's the one I know.
That is the only one that you know. Okay, you have done well. I've mentioned one when I was doing legs with you.
So is it refractory hypokalemia?
You're asking me. I'm asking you a question. Hilary, are you there?
Yes, please.
Can you tell me one? Hmm?
Now,
Come again. You state 4 conditions that could lead to optotoxicity when using lasers. So hypoproteinemia, what again?
Hello.
Hello.
And using a higher than recommended dose or
Come
a
again.
fast infusion rate of furosemide.
Come again. Efia.
Using a higher.
Good. Efia. Good. So excessive dose of lasers. Excessive dose could do that. And rapid IV administration. Excessive dose and rapid IV administration could do that. When I was doing edema, I mentioned this. I mentioned the rate. And tell me the rate. When you are given IV lasers, what should be the rate? What should be the rate when you are given IV lasers?
So you mentioned 4 milligram per minute.
So 4 milligram per minute. That should be the rate. So when you exceed that rate, I told you patient can also experience ototoxicity when you exceed that rate. That becomes the rapid IV administration. The rapid IV administration could lead to that exceeding rate of 4 milligram per minute. Excessive dose. So any other? Any other? Hilary, mention names for me.
Caleb.
Mention 3. So
I think dehydration.
Dehydration. Dehydration is not part. Any other? Okay, so the next question was what? What was the next question?
Why are diuretics contraindicated in Addison's disease?
So who can tell me? So what is Addison's disease? That should be the first thing that you should answer. And why is legs contraindicated in Addison's disease? The next question is what?
When should legs be taken in relation to food?
Okay, so tell me. How are you going to cancel your patient? Legs and food. When should the patient take the legs? When should the patient take the food? Who is answering that for me? Oh, mention anybody's name.
Stacy, please answer. Stacy. Ivan, please answer.
Please, legs is taken before meal.
So legs should be taken before meal. So on an empty stomach. So in your counseling, please note this. I know these common things. You are not thinking about these things. Be careful about your careful. Be careful about the way you are learning. Be careful. If I ask you to differentiate between indapamide and Benadryl, can you do that for me? And Benadryl.
Doc, please. Indapamide is a thiazide-like diuretic, and then Benadryl is a thiazide diuretic.
So that is one of the differences. Any other? Any other differences between the two? Any differences? Who can help me? Any differences?
Doc, please, with indapamide, it comes as a sustained release tablet.
Come again.
is with indapamide, it comes as extended release tablets, whilst Benzo does not come in that form.
Indapamide come as sustained release tablet. You said indapamide comes as what? Sustained release.
Yes, doc.
Someone. Why are you saying this? What is the effect? I just want to open your eyes to these small things. Hey, class. What is the effect if you give low dose indapamide? What will be the effect if you give low dose of benzo? What will be the effect? Richard Menu.
So, I think, indapamide at low dose, it's a vasodilator. It's a vasodilator at low dose when you give indapamide, but at high dose, it's a diuretic.
Good. Benzo.
Benzo has a diuretic property at low dose, because benzo, if you give a higher dose, you increase the side effect.
So the thiazides, they have low ceiling effect. So if you give them higher doses, I'm just
So benzo is a low ceiling, while indapamide is high ceiling.
Kinsley. Is it Kinsley? Kinsley is also saying benzo is what? High ceiling.
No.
Kinsley,
No, low ceiling.
Low ceiling.
Benzo is low ceiling. Drugs like diuretics, while the indapamide is high ceiling diuretic.
So do you agree with Kinsley? Class, do you agree with Kinsley? Class, you are not talking. Do you agree with Kinsley? Ivan. Is Ivan around?
Yes, please, I am.
So do you agree with Kinsley?
I'm not.
Come again.
I'm not sure, sir.
Yeah. Do you know what? I am going to do this more. And it's better for me to disgrace you here and pass your exams at the end than to pamper you. So I'm going to do this more. Ask small questions. More. I'm asking, Kinsley said that benzo is what? Low ceiling, and indapamide is high ceiling. Do you agree with Kinsley? Kinsley, why do you say this?
Doc, this
Come again.
Doc, this Samuel.
Yeah, hello, sir.
Samuel, okay.
Please, I agree with Kingsley, because previously we said that indapamide at low dose serve as a vasodilator. So at high dose, it will serve as a thiazide-like diuretic. So indapamide will be a high ceiling dose, and then benzo will be a low ceiling dose.
So you agree with Kingsley?
Yes, Doc.
The same.
Kingsley, you agree with Kingsley? Samuel, please, hey, for high ceiling effects, it's loop directives, which comes out with these high ceiling effects. It's not the thiazide. Take note. You get me?
Doc.
Kingsley, you get me? I am saying
Yes, sir.
it's the loop. So high ceiling effect medications are the loops. So the more I increase the dose, the more that is why you can increase the doses of Lexis and co because of this high ceiling effect. But thiazide, when you do that, you are going to put the patient in a bad position because the patient will experience more adverse effects because of his low ceiling effect. So the effect is obtained when you have low doses. So when you're increasing the dose, you are just increasing the metabolic side effect. This is general under thiazide. Kingsley, you wanted to say something.
It's okay.
Tell me. You wanted to say something. Kingsley,
Oh, Dr. Attakorah, I'm fine. Yes, sir.
you wanted to say your jazz, so tell me.
Oh, I'm fine. You explained it too.
No, I want to know that side. Whether you be telling me again. I am going to do
Oh,
these
I wanted
things.
to say that.
I'm listening. Kingsley, I'm listening.
Oh, you just explained it. The same thing I wanted to say, just in addition to what Samuel said. But then
So tell me
that was where you
your
corrected us and you
tell
explained.
me your portion.
The more you increase the dose, like the patient wouldn't benefit, but then it will increase the side effect. That was what I was trying to say.
So that makes it what? That makes it a low
A low
ceiling
ceiling
effect. But advantage of using the indapamide is that the indapamide had reduced metabolic side effects. Assuming we're using a potent dose of benzo and indapamide, the indapamide will give you less side effect as compared to what? As compared to benzo. Please, you get me?
Yes, sir.
Last question, then I start. Tell me the effect of benzo on calcium, effects of Lexis on calcium. You get my question? Effects of benzo, effects of Lexis on calcium.
I think it's, I think it's hypercalcemia.
Kingsley, what happened? If you are closer to me,
So then it's hypocalcemia.
I've mentioned two medications. These medications, I've mentioned these two medications. I've mentioned Lexus. I've mentioned Bengu. Kingsley, can you mute? The noise is coming from your side. I've mentioned Lexus. I've mentioned Bengu. I just want to know these two medication, effect of these two medication on calcium.
That the benzo will cause reduced calcium excretion, and so there will be more calcium levels in the blood. And then the furosemide, which is the loop diuretic, will cause excretion of more calcium.
Any other? Kingsley, can you help me? Samuel. Okay, so let's start. Have I done this with you? Uremic gastritis, uremic encephalopathy. Have I done that with you?
No, please.
Have I done? That's why I'd wanted to know what I've done with you. Have I done? I've done anemia. I've done metabolic acidosis. I've done
Yes, please.
hyperkalemia. I've done edema. We have done osteodystrophy. Have you done that?
Yes, please.
Okay, so let's do the uremic gastritis. So come again. Come again.
Done that one.
We have done uremic gastritis.
Yes, please.
We have done. So tell me what we did under uremic gastritis. We have done uremic encephalopathy. Hilary, check and let me know.
Yes, please. So please, we spoke about uremic encephalopathy, and we spoke about under it, we spoke about diuretics and then dialysis. And then under the gastritis, we spoke about the use of PPIs. That was it.
PPI. So what did you say about the PPI?
So one thing you kept emphasizing on is that if the patient has some of his or her nephrons intact, we don't use the PPIs, we use the H2 receptor antagonist instead. And then if the person is at the end stage, the PPIs are used to manage it. And we also said that the PPIs can cause interstitial nephritis, and that a full dose of the H2 receptor antagonists are not given. That's if the patient has if the original dose is given, it can have the same effect as the PPIs.
So what do we do? So the dose. what do you do about the dose?
You reduce it by half.
So in that reduction, what do you do again? So the dose is what? And when you reduce to half, it becomes what?
So we give an example. Ranitidine. You do 50 milligrams TID instead of the original 100.
Okay, then it means we are through with this. Most of the clinical manifestations we are through. Is the basically we are through with, but other small presentation can come. Anemia can also present with other, but let me say in person, let me say this about the PPI. When you are, because PPIs can cause interstitial nephritis. So when you're giving it to a patient, CKD patient, we prefer to use the H2 receptor antagonist. But listen, when we are using it for short time, we can say, let's say 1 week, 3 days, 4 days. But if the patient will be on it for a long time, then because of these interstitial nephritis, that could affect the remaining nephrons. We will not like to go into that. It's not only PPIs that could cause interstitial nephritis. Other medication can cause that. So please know that, such that you won't think about only PPIs. Who can tell me 1 or 2 medication that can cause interstitial nephritis? Who can tell me 1 or 2 conditions, medication that can cause interstitial nephritis? Class, who can tell me 1 or 2 medication that could cause interstitial nephritis?
Allopurinol.
So allopurinol could do that. Allopurinol could do that. So if a renal patient comes with gout and want to give allopurinol, how will you go about it? And if you don't want to give allopurinol, which drug will you give? Because of this. So let me ask you this. Why will you not prefer to give allopurinol in a renal patient? If a patient comes with gout, please, are you with me? I will be asking you questions. Because these will put you on your toes and it will open your eyes to in your reading. because you have more MCQs, and anything can be MCQ. So allopurinol. So in renal patient, if I ask you, why will you not give allopurinol to a renal patient? Who can help me? Della, can you do that for me? Hilary, mention their names. They can't hear me. So if you mention their names,
Would it be because that's
who is talking?
Sandra?
Sandra, good.
Please, will it be because that allopurinol is excreted renally, so like in a renal patient, you'd want to maybe give a lower dose or not give the allopurinol.
Sandra, the way you started, as if you are asking me, will it be? Were you asking me or you were telling me?
I was telling you.
Okay, so if you are telling me, you are right. So take note of this. Allopurinol is excreted via the kidney. So if you want to use that, then, but mind you, allopurinol can also cause what? Interstitial nephritis. And therefore, if I don't want to use allopurinol, which drug will you suggest that we should do?
Can you use corticosteroids?
I use what?
Corticosteroids.
Idella. I don't see your faces. Ejuma needed demono. I don't see your face. Della, renal patients, will you be okay to use steroids in CKD patients? Will you be okay to use NSAIDs in renal patients? Della, will you be okay to use why am I talking about steroids in renal issue? If a patient comes with CKD, if it's nephrotic syndrome, I'll be okay when you're using the steroids.
Please, I've changed my mind. I think we should use febuzostatin instead.
She used Fevisos. Hello, hello, class.
Hello.
It's. I went off a little. My internet was disturbing me. Okay, so let's do that. Let's start with the acute. The acute. Any question about the chronic kidney disease? Any question about the chronic kidney disease?
Dr. Attakorah,
Hello.
yes, please, for the management of the hyperphosphatemia, we mentioned aluminium hydroxide, calcium acetate, sevelamer carbonate, and then lanthanum. But then we spoke about only the aluminium hydroxide in the. So we were wondering if we would talk about the rest, like the way we talked about the aluminium hydroxide.
Do you know the commonest ones that we used here is what I've talked about?
Okay.
Mm-hmm.
Yes, please.
That is why I was asking, I was asking you about what we used. The institutions that you are, what do they use?
I've not come across the use of these agents yet.
Yes, so normally it's better if you have an idea that they can use A, B, C, D. But what you use here, you should have an idea that they can consider the acetate, they can consider lanthanum, they can consider A, B, C, D. But if at the word, if you suggest that they should use this and they don't have, what would be the benefit? So you should know that you could consider this medication. I don't know whether Accra they have this. They have any of these medications there. The guys in Accra, what do you use to manage? Can you hear me? Those in Accra, Kwalegu. You see, where are you? Joseph, where are you in Kwalegu?
No, please.
No. Where are you?
International Maritime Hospital.
International, there you be having a lot. So do you come across renal cases?
Yes, please.
So tell us, phosphate, what do you use to manage the phosphate levels?
I've only seen aluminum hydroxide.
I've only seen aluminum. That is what you use to manage that.
Yes, please.
You are international, so so Hilary.
Not Attakorah.
So even aluminum hydroxide is not the commonest that we do in Ghana. The spectrum, I'm not getting the spectrum. We have these medications, the medication that we touched on, but it's not common here. That is why I was asking you I wanted to know whether you have seen these agents being used in. We have loop diuretics, but we tend to dwell more on lasers. Bumetanide is there, but we don't normally use bumetanide because it's more expensive. But bumetanide is being used. So when you are talking about bumetanide, but other loops, that is why I'm comfortable talking about the aluminum hydroxide and calcium carbonate. Are you okay?
Yes, please.
But you should know that we have these other medications that could be used to manage this and this. Okay, so let's do the acute. If you don't have any question, you see, if you don't have any question,
No, please.
Josephine, upon no question. If you have what thing? Okay, so let's talk about the acute. The commonest clinical conditions, the renal condition that come, and it's difficult to manage. Difficult to manage. Nobody talked about hypertension. Hypertension is there, CKD, and it's difficult to manage hypertension. And you should know the medication that should be used to manage hypertension in CKD. So let me quickly discuss this with you. So let's discuss. I don't like the way you do discussion with me. You don't come out, If a CKD patient comes with high BP, tell me some of the medication that could be used in the management of the BP, bringing the BP down in CKD patient. Because they will also come with, tell me some of the medication and those medications which shouldn't be used in CKD. Do you get me?
Yes, sir.
Okay, so tell me some of the medications. I want it to be practical. Those we have seen at the ward.
I think you'd use the ACE inhibitors and then the ARBs because they are nephroprotective.
So when should we avoid ACEI? As a renal patient, Sandra,
Dr. Attakorah.
when should we avoid? When should we avoid this? We can use this. We can use the ACEIs in CKD patients to reduce the BP. And there are certain instances that we need to also avoid. So tell me, we can use that.
So you'd want to avoid it in bilateral renal stenosis.
Mm-hmm.
At least that's all I know.
Any other?
And maybe like hyperkalemia or something.
When a patient comes with hyperkalemia, any other? So CKD patient who comes with hyperkalemia, it means we shouldn't consider ACEI. And you said that these, when you have bilateral renal artery stenosis, you shouldn't also use that. But hey, Sandra, do you understand why we should avoid? We should avoid ACEIs in these stenosis, bilateral renal artery stenosis. Do you? Can you explain to me, Sandra?
No, please, Dr. Attakorah.
So for your assignment, I'm giving you, Sandra, your assignment. Find out why we shouldn't. I've explained this to you. I've explained when I started this. It's just the application. Okay, so you can use ACEIs. Can use losartan in the management of BP. Sandra said that because it has a renoprotective effect. So when you want to use ACEIs, now the kidney is damaged. You still consider it as a renoprotective. Sandra. So you shouldn't use ACEIs when there's high levels of
In pregnancy, sir.
in pregnancy. One last, I'm talking about CKD. In pregnancy, you shouldn't use what? ACEIs. In pregnancy, you shouldn't use ACEIs. But in CKD, can you hold on? Hold on for me. Sorry. Nothing I could do. Okay. Huh? Serious. Hey. Hey. Mm-hmm. Hello.
Hello.
So CKD patient, tell me if I ask you conditions that you avoid ACAIs in CKD patient, please, you should know. You should know. You have touched on. Somebody said pregnancy. That's outside that. So in pregnancy, you should avoid that. Pregnancy, you should avoid that. So what again? Somebody said, Sandra said stenosis, bilateral renal artery stenosis. What's the last one about CKD that you should avoid? ACL. Who can help me? Samuel Donko, can you do that for me?
Some also said hyperkalemia.
Hyperkalemia, good. So in hyperkalemia, what again? There's one which is common, and you should know that. Who can? Samuel, can you do that for me?
Please no.
Howard, can you do that? Who can help me? Come on, please, hurry up. So when a patient comes, a CKD patient comes in acute, it becomes acute on chronic. You shouldn't use ACIs. ACIs shouldn't be used in acute state. So in acute on chronic, we shouldn't consider ACIs. Please, is it clear?
Yes, please.
So hyperkalemia, renal artery bilateral, renal artery stenosis is bilateral. Renal artery stenosis. We talked about hyperkalemia. And the last one that you need to know is the acute. When the patient comes with acute, so in acute state, don't consider ECE. And you know the reason. I've done this with you. Please, do you know the reason? So any other antihypertensives that we can use in CKD, any other antihypertensives? Oh, antihypertensive.
Sir, can you use metal-dopa?
Can you use metal-dopa? Metal-dopa is centrally acting. So you can use metal-dopa. What again? So when you are using metal-dopa in renal way and want to initiate it with smaller doses first because of its side effect. You should initiate it smaller doses because of its side effect. Any other? So we can consider metal-dopa. What again? Hurry up. Medications, antihypertensives that we can do. You can consider CCBs. You can consider CCBs in renal. Any other?
Diuretics.
Can consider diuretics. Good. Can consider diuretics. Any other?
Beta blockers.
Can consider beta blockers. So can you tell me one advantage of using beta blockers in CKD patients? One advantage. So beta, do you know that beta blockers, they have effect on renin release? Do you know this?
No, sir.
So beta blockers also have effect on the renin release to inhibit the release of renin. And that will reduce this overload, fluid overload. Because renin is being prevented, fluid overload will be reduced. Okay, so back to our main topic. Let's move on to acute kidney injury. Acute. So we have talked about chronic, we talked about acute, then we do a general. The labs that we take. I want to do the details of the labs. I'd like to do the details of the labs. And you should expect these questions. Detail of the labs. If a patient comes, let me ask you one lab. If a patient comes to you, the patient tells you that if he or she is voiding, he or she will be seeing blood at the end of maturation. If a patient tells you that at the end of the voiding, you'll be seeing blood, well, seeing blood at the end of the voiding will point to which part is the patient bleeding from? So we'll be doing the labs in detail. Because in CKD, you need to do, for the CKD, you need to do the urea and creatinine. But I want to take the labs detailed, cover everything under genital urinary disorders, cover everything. So take note of that. You do. So when you finish that, you do the lab. So when you talk about acute renal failure or acute kidney injury, you either call acute kidney injury or acute renal failure. This is a common and a serious clinical condition. This is a common. It's a common thing that happens. Common thing that happens in our setting. Acute kidney injury or acute renal failure. Why is it common? Who can tell me why this condition is common in our setting? Why is it common? Who can tell me? Is Gloria around? Why is AKI common in our setting? Efia, can you help me? Efia, what?
Abuse of over the
It's because of abuse of over the counter. Asking a lot of questions for a purpose you don't know. Because of your aura. So please, I am begging you, if you are answering questions, know that the follow-up questions, you know the follow-up questions. And because Kingsley, you said because we are abusing NSAIDs. And the follow-up question is, how would NSAIDs cause acute kidney injury? You get me? Kingsley, do you get me?
Yes.
So how will it cause?
Please, no idea.
No idea. So I'm saying be careful. When you are answering questions and you don't know the follow-up questions, please don't rush to say this. NSAIDs could cause that. How will NSAIDs cause that? You should know. So I'm saying AKI is common. Why is AKI common? Who can tell me? Why is AKI common? Hilary, can you call somebody?
Yes.
Is Kojo around? Is Kojo around? Hilary, Kojo is not around. Okay, so AKI is common. That's any condition. A lot of condition can lead to AKI. A lot of condition and condition medication could lead to acute kidney injury. So a patient coming with malaria can lead to acute kidney injury. A sickle cell patient can come with acute kidney injury. Taking NSAIDs, as Kingsley said, can lead to acute kidney injury. dehydration can lead to acute. So it means anything can lead to acute kidney injury. And that makes it what? Common. It's a common and a serious condition. Very common, but serious what? Condition. Very common and serious condition. Because any condition or a lot of conditions, dehydration could lead to acute kidney injury. So note that. So when you talk about acute kidney injury, it's characterized by a sudden reduction of renal function or kidney function, sudden reduction of kidney function. And the kidney function is to excrete the waste and the fluid. So sudden reduction of the renal or the kidney function is called acute kidney injury when there's a sudden reduction. And the sudden reduction, please, it's not only sudden reduction, it's sudden reduction within 48-hour period. Within 2 days, if there's a sudden reduction, within 2 days, sudden reduction of the urine output or the renal function, we term it as acute kidney injury. And this sudden reduction of urine output or kidney function will lead to accumulation of what? Nitrogenous waste, or will lead to azotemia. When I say azotemia, what does it mean? Waste product and other toxins. And I'm using the word azotemia. What does it mean?
Is the elevation of urea and other nitrogenous waste substances in the blood.
Elevation of urea and other nitrogenous waste. Accumulation of this we term as what?